Are not doing this in the morning. It's Chelsea and Sarah with Wound Care University, and we're going to be chatting with you guys today. It's kind of a fun one, I think.
Oh, look, we can
Nothing.
cheers our coffee. Cheers.
Cheers. Um, this is only like halfway through the first cup, so I'm still processing. There's a little
Still
bit of a
catching
lag
up.
here. Yeah. So today's topic is going to be not anything heavy. I feel like sometimes these can get a little like, oh, wow, that was very sciencey. But today is going to be kind of a fun one. We're going to talk about the Wound Care Hall of Fame and the Hall of Shame. So I think we can start off with the Hall of Fame, our faves, before we start dogging on some techniques. So we'll start off with moist wound healing. I know that people don't like that word, so maybe we won't say it as much, but that's kind of like the optimal wound environment. And I don't know if you could speak to this, how often you hear people say that you need to let a wound dry out, but kind of what that means to you when you hear that.
Yeah, so it's pretty old school thinking that we need to dry things out. The moist wound healing environment is the ideal place for our wounds to be, unless it is stable eschar, right? So that would be the only caveat here, that we don't want a moist wound healing environment. Now we can be too moist, and we can be too dry, but that's what the benefits of foams are, is that they can help you kind of balance that. And if wound care was a one size fits all, then it wouldn't really be a specialty, right? So, keeping that moist healing environment is, and I think I just said that word like 6 times in that.
The ones out there cringing right now.
Yeah. So have fun with that. But yeah, making sure that that wound has its optimal moisture in it is one of the best ways that we can heal. I'm rambling again. Coffee has not kicked in yet. So,
Yeah, I mean, I think that that's you hit all the points. Also, too, I think something people forget is when wounds dry out, they can often get really painful. And keeping the environment optimal and kind of supple in those tissues prevents it from feeling really stiff and painful for our patients too. I was at a parade on Saturday and I got this random scratch right here that ended up being really deep. I have no idea how I got it. And I was just busy. I let it dry out. And it was so tight that I was like, oh my gosh, like this is such a thing. And as soon as I put Medi Honey and a little bandage on it, I felt great again. So
yeah,
it's a real thing.
exactly.
Next for our Hall of Fame section, I think should be offloading, especially for DFUs. That I think is such an integral part of healing, and it's often overlooked. And patients, I think, have the hardest time kind of following up with that one too. It's definitely tricky. But I think there's things that can definitely improve patient adherence with that, like things that you don't have an option in, like a TCC. Because a boot, you can just say like, this doesn't go with my outfit, I'm not going to wear it. But a TCC, you're committed to the bit with that one for sure.
Yeah. And
You can't.
TCC is a total contact cast for
Oh
those
yeah,
that don't know that, and are joining us today.
yeah,
But yeah, it makes our non-compliant patients have to be compliant, which is a really great thing. We know that sometimes when we order offloading shoes and boots and things like that, you just think, oh, I'm going to get up for just a second to do this. And then you end up doing 15 things around the house and you're not offloading at all.
yeah.
And we know it can be frustrating, but we promise as soon as we can get that wound healed and things working the way they're supposed to, it'll be worth the wait, to be compliant in those situations. And there are very poorly fitting diabetic shoes out there, so you really need to do your research and who you're getting those from. We've had
Yeah.
several patients who had a ulcer because of that poorly fitting diabetic shoe.
Yeah.
We healed it, then we sent them home, and they put that same poorly fitting shoe back on,
Yeah.
and got it away. So make sure they throw that one away, whichever one caused it, if they do have one. That's a big deal.
Absolutely. I mean, I keep telling patients, well, back when I was seeing patients on a regular basis, I can put an expensive skin graft on this thing. I can do all this crazy stuff. We can do the debridements, we can do hyperbarics, but I can't outdress a wound that's under pressure. And it's like, the comparison I would always kind of draw is like, imagine that you are trying to build a fence and you're putting the bricks up And every day you come back, someone came overnight and knocked all the bricks down that you put back yesterday. That's how your body feels when you're trying to heal a wound. And every day you're just putting more pressure on it, destroying those building blocks. Like you're never going to make any progress.
Exactly. So two things is offloading and nutrition. If you don't have those two things, we can throw every expensive wound care product at you and you will not heal.
Not going to heal. You're so right about that. Nutrition is such a big thing too. Um, On to the next one, compression therapy. That's a really big one. Complete game changer for venous leg ulcers. Um, and I don't know if you can speak to this too, but do you think that edema control in those patients is potentially more important than the kind of dressing itself that we're putting on there?
100%, 100%. I actually just did by the time this comes out on our channel, will be a micro session up on compliance and compression. That's actually coming out a couple of days from now, which will be before this airs. So it's a big deal. You got to think of it like traffic. So it's like congestion in that area. Nothing's getting there. The oxygen, the molecules are having a hard time getting to that wound to help heal it. And it is a slow process. And compression feels to patients like almost like a punishment, and it really isn't. I can understand that, and especially in Texas when it gets 100 million degrees outside in the summer, that's the last thing you want, right? But if you don't have that compression, you will not heal. And of course, we want to make sure that you're compressible. So make sure you follow the orders and stuff of the physicians that you are seeing, because sometimes people aren't compressible, and then we have to get vascular involved and all of that stuff. And it does take a team. So I think you hear us preach that pretty often.
Yeah. So that kind of segues, I think, into the last thing we can chat about for our Hall of Fame before we move on to shaming people and causing controversies, which is multidisciplinary care. And this is something I know that we preach heavily in Wound Care University and in some other projects that are kind of upcoming too, is that our philosophy as an industry needs to be treating the whole patient, not just treating the hole in the patient. So that means we have to work with vascular, we have to work with endocrinology, we have to, like you mentioned earlier, really work on nutrition. Sometimes that means we are working with infectious disease. Is there anything else you can think of, anyone else that needs to come into the picture there, and how we can best communicate with those teams?
Honestly, I mean, of course, they're primary as well, and really anyone who's involved in their care, their caregivers, right? Whoever is managing that piece. And a big thing for me is since our sister company took on vascular, I've really understood it a lot better and won't take no for an answer if I don't think that should be the answer. So, meaning if you need a second opinion, get one. The patient's limb is relying on that. So let's find somebody who's willing to put in the work in the cath lab and the OR and things like that, because some people just aren't, and that's okay. I mean, they're not all the same, right? Just like Chelsea and I would treat a wound differently that we're looking at the same exact wound. So just get that second opinion if something in your gut is telling you that you should. Right. Again, it is a limb saver. I mean, that's what our goal is here. So I think that's the biggest piece. And also with ID, you might see some ID docs that are just throwing antibiotics at certain things when the patient's actually colonized, and we're over culturing things and just treating everything that's there. And this patient's had this chronic wound, which, I mean, we all know that you're going to get Pseudomonas in there at some point in your open wound part, and you can heal that. I mean, you can get rid of that with creams, and you don't have to do antibiotics, IV or PO. And then any other thing that's actually colonized, if they're not showing true signs and symptoms of infection, sometimes, consults can kick you in the butt if it's not what you want.
Yeah. I always tell patients you got to be careful because you end up with a chronic wound and chronic diarrhea. So
yeah, we don't
got to be careful with antibiotics. Because I've had patients before that will see and say, like, yes, your culture has bacteria. Your skin has bacteria, your wound has bacteria, but there's a difference. Like we talk about this in some other episodes, like with colonization and infection. So they would go to other doctors. They'd go to like their PCP or urgent care and get prescriptions for antibiotics. So by the time they came to us for their next appointment, like, oh, well, I actually just did another course of Bactrim. I went to urgent care. And it's like, you're just making a mess for yourself. Please don't do that.
For sure. And people culture wrong. I mean, I remember when I first got into wound care, I had an ID doc that would culture every single wound on the patient with the same culture swab.
Oh my
And
God.
so that's kind of how I learned, right? Which is really bad. And then also just grabbing the nastiest piece of the wound and culturing that when in reality you're supposed to clean the wound appropriately
Yeah.
and then, do that Levine technique from the center all the way to the
Yeah.
outside. But so people don't know that. It's not common knowledge, especially if you're not the wound care nurse doing these things and the nurses on the floor are doing them. And they're in their mind, it kind of makes sense to grab the nastiest stuff in the
You would
wound,
think,
right?
yeah.
So
So I guess that kind of
what about debridement? Did we want to talk about that?
oh yeah, debridement. Yeah, that's definitely going to be Hall of Fame for sure. There's all different types. There's what sharps, enzymatic, autolytic, mechanical, biological, all very
Maggots.
important. I get sometimes your patients just show up with those for free.
Yeah, they didn't have to pay the millions of dollars to ship
Thanks.
them from a sterile location. It's pretty exciting.
Exactly. And we've talked about this before. We've had, I think, whole episodes and like, little sessions on debridement and biofilms and all that good stuff, and how important it is to get that dead tissue out of there. I'm always talking to patients and staff, educating on why it's important to get the slough out of the wound. So if you can imagine that, like, the slough is like the pool cabana umbrella, and all the bacteria are having a party underneath there, and they're having their bevies and their chips and guac, and you can keep dumping as much antibiotic creams on top of it as you want. It's not going to be able to penetrate most of the time. Yeah. So until you can take their umbrella off and get to them, you're kind of in a situation. So it's important to get that out of there.
Analogy. Love it.
Relatable, especially for summer.
So enzymatic debridement, it can be helpful, but it's slow, right? So if we can do it in conjunction with sharps debridement, it's a great thing. Your autolytic debridement is basically your body doing it for you. So eventually, maybe, if it doesn't get infected and then have major treatments, if you just put a Band-Aid on something and keep it on, your body is doing the autolytic debridement. Every dressing you put on that wound has autolytic properties and that, so it'll help it. But again, it's just very slow. There's a caveat there too. If you have an atypical ulcer called pyoderma gangrenosum, you will not debride that wound. And sometimes the only reason we know it's pyoderma because they mimic arterial ulcers and lower extremity ulcers is when we do debride it and it gets worse. So just know that there. But for the most part, sharps debridement should be a first line of defense in this in most situations.
Absolutely. So I think we can go on to Hall of Shame.
Hall of Shame sounds good.
Time to upset some people. I would say the first one is letting it air out. We kind of talked about in the first one, we want to keep it moist. So major Hall of Shame is leaving things open, dry to air. And I cannot tell you, and I know you've heard it so many times too, patients come in for follow-up appointments with the dressings off, and you ask what happened here. Like, oh, well, it was draining, so I took the dressing off so it can dry out. Well, you just killed all of your epithelial tissue. So let's start back over. Yeah, it's a no-no. Scabs are not a sign of healing, especially in chronic wounds. If you have like a little scratch or something and you're a healthy person, a scab, whatever. When my 5-year-old has a scab on his knee, that's okay. He's 5. But, when you start thinking of scabs as more as like, oh, that's actually not a scab and that's a big old dry eschar you got there, it's a little different.
Yeah, I agree. I was looking at the next one about hydrogen peroxide and alcohol into every wound, right? So the cytotoxicity there is a big deal.
Yeah.
I do love hydrogen peroxide for like my own things, but not for chronic wounds, not for treatment of those because of the cytotoxic properties. But it does kind of remind me of when I was a kid and I have a scratch or something on my leg, and we'd be down at the
Yeah.
beach, and my parents would say, "Why don't you just run in the water? I know it'll sting for a little bit." And now we're seeing all this necrotizing fasciitis come out of that. So thank God that didn't happen to me when I was younger.
Yep.
So let's maybe not do that moving forward. That's a myth, probably.
Yeah, I think it's a bad idea. I mean, it's great for getting blood out of your scrubs or your lab coat,
Yeah.
but that's kind of the only time I want to see it in a wound care center.
Swimmer's ear.
Yeah.
Yeah. Just maybe
But
not. I've had some surgeons order a hydrogen peroxide washout, and it actually wasn't that long ago.
yeah,
And you might know who I'm talking about
I
here, but
do. There was a
um,
hydrogen peroxide hand soak, if I'm thinking of the same
no,
person,
this is
even.
I think it's the same doc, but a different it was an axillary wound that actually tunneled, and it was
Oh, okay.
you threw in a bunch of hydrogen peroxide and then hope it came out eventually. Um, so anyways, let's not do that.
No.
Oh, wet to dry dressings.
Wet to dry. Isn't that, I think
My
that's
arch
illegal
enemy.
in the state of New Jersey. Like it's literally against the law. I'm not even joking. I think it's illegal in the state of New Jersey.
Oh
Like they
my
have
goodness.
outlawed it. Just to give you an idea of how bad it is, it is against the law in some states. So
Yeah, it hasn't been
don't
a
do it.
standard of care since the 80s. However, we do have lots of surgeons still ordering this stuff. And our best conversation with them is hopefully they'll let us take over the care, right? And usually when they're doing a wet to dry dressing, the wound probably should be on negative pressure. And not every time, but most of the time.
Most of the
It's
time.
decent enough, deep enough wound that requires negative pressure of some sort. We try to talk them into wet to moist dressings. If we can't get them to let us fully take over their care. So it's just it doesn't heal, right? Then you've got that mechanical debridement happening that maybe you don't necessarily want. The mechanical debridement isn't slough oh my god, slough specific or
Yeah,
wow, I'm having a stroke. Oh god. Necrotic tissue
there we go.
specific. So if you're pulling it off, it's hurting your granulation tissue as well. So
Yeah.
it's
And very
something that
painful
we
for the
really just shouldn't
patients.
be doing. Plus, all the hands in there, if you're changing it 2 or 3 times a day, it's an infection risk. We don't
Absolutely.
need that many hands in these wounds. That's one of my biggest pet peeves is the amount of times people change dressings when they don't have to be changed more than a couple, 2 or 3 times a week.
Absolutely.
And people are changing them daily and every other day and
Twice a
sometimes twice
day.
a day. Yeah,
Yeah.
it makes me crazy.
Yep, absolutely. And it's also needlessly painful for your patients when they're, we talked about how like a dry wound hurts. And if it's a dry wound and it's also non-selective, so you're just yanking out good tissue on a dry wound, I've never dealt with it, but I've seen it happen and it seems incredibly painful. I think the next one we can move on to is treating every red leg with antibiotics. Not, I mean, we've talked about this already, kind of like antibiotic overusage. Not every wound needs an antibiotic. Not every, I guess, source of redness is because of infection either. So what's the other
Every
thing
red
if it's,
leg is not cellulitis.
yeah. So what could it also be if it's not cellulitis?
Stapes dermatitis, some
Yep.
venous insufficiency situation, people
Hemosiderin
sitting
staining.
dependently
Yep.
constantly, um, all of those things. But yeah, it's the treatment, and you see this all the time. I mean, we see it with our providers too. So
Yeah.
it's just an area of education. It is an area that needs more education to come out, and maybe that's a new micro session topic for me, but um we can put something together for that because it is a big downfall.
Yep. Let's see. This wound just needs more time. I've heard that plenty of times from some providers where like, oh, well, let's just give it a little bit more time. Let's try something new and see. And I feel like when we just say like, oh, it needs more time, really don't want to wait longer on a wound, especially when you know how bad things can turn in folks that have a lot of comorbidities. You end up sometimes missing big cues for like arterial disease, venous insufficiency. We're missing maybe the fact that their nutrition is kind of trash and should be addressed. So we really don't want to give things more time. Like, let's not be overly aggressive, but if
Yeah.
someone comes to you with a problem wound and they especially have other comorbidities, let's get to the point
That
there.
is the delayed referral is a big thing. I mean, even
Yeah.
to just like the primary to wound care, the delayed referral there is is very important, imperative. Delayed referral to vascular, same thing. We're trying to save limbs in this day and age. And those delayed referrals can really make a difference.
Absolutely. So I think we can move on to our rapid fire if we have
Okay.
a little bit of time. So we'll just throw out some things and we can say if it's Hall of Fame or Hall of Shame. So if a patient tells you that they want to leave their wound open to breathe,
Hall of shame.
Hall of Shame, straight to Hall of Shame.
Yeah.
Let's see, compression for venous ulcers,
Hall of
Hall
fame
of Fame. We
all
love to
day
see it.
long.
Hydrogen peroxide for every dressing change for cleansing the wound.
Shame, shame, shame.
Shame, shame, shame. Nutrition consults.
Fame.
Same, yes. Same offloading,
Fame.
2 thumbs up. Wet to dry. We talked about that. That's big Hall of Shame vibes there.
Yep.
Wound vacs, negative pressure wound therapy.
I mean, I think it could go both ways, right? So we don't need
Yeah.
over usage of these things. But mostly it's a Hall of Fame. I don't think I would
Definitely.
ever put it in the shame typically, but I do think there's some over usage here.
For sure. And the last one, using normal saline to cleanse. I'll give 1 thumb up because it's
Yeah.
not always appropriate, right? But generally Hall of Fame, right?
Yeah, if that's all you have, absolutely. There's so many things, so many products out there, and you don't need all the fancy stuff. And that's not what we're saying at all. So, if all you have is soap and water, that's what you can use. But we want to use some type of wound cleanser if you got it available to you.
Yeah. So last one, if you're willing to spill a little bit of tea, what do you think that we're using now in the industry might be in the Hall of Shame in the next 10, 20 years?
What are your thoughts on that one?
I
don't
won't name
know.
any product names because
Yeah.
I don't enjoy a lawsuit, but I think that there have been some skin sub adjacent products that might not have a ton of efficacy.
Yeah, I could see that. I mean, and with all the skin sub changes, you would have thought that those would slow down, but they really haven't.
Yeah.
And sometimes it's like, are they really skin subs or are they just collagen
Very
with a little
expensive
extra umph? You know, I
matrices
mean,
of some kind. Yeah.
yeah. Don't shoot the messenger. No, I'm kidding.
No. And there's
No,
some
I
really
love a
good
skin
skin sub
sub.
products
Yeah,
too.
and they're used when necessary, but the reason we're in this position is because they were not used when necessary in a lot of ways. So that really sucks for everyone who was using it appropriately. So
Absolutely.
here
Yeah.
we are trying to fight for our lives in wound care.
This is why we can't have anything nice.
I know.
It happened to hyperbarics. Oh gosh, what, probably 10, 12 years ago now. I mean, I've been doing this for forever, so it flies by. But we had the same thing happen where things were going well and people started abusing it for, skin grafts and flaps that were from 8 years ago. And then
Yeah.
we got a bunch of our fun taken away for our patients. So
Yeah. So just do what's right.
just do what's right.
And
Gosh,
ask a
guys.
question if you don't know the answer. To anyone.
Yeah.
Somebody knows the answer.
Easy peasy. Well, thank you for chatting today. I think this was awesome. And we'll be back
Yeah,
for
I
another
enjoyed it.
one before you know it.
All right.
In a
Thanks
little
for
bit.
joining us.
Bye.